You got that? Hold on. Thank you. Welcome, everyone. I'm really happy to be here today. My name is Rebecca Penn, and I work for the London Intercommunity Health Centre. I'm the project manager for the National Safer Supply Community of Practice. And together with the LIHC Safer Opioid Supply Program, we're co-hosting this event, which we've been really looking forward to, sharing the results of the program's evaluation report. So I'm going to start off today by doing a little introduction. The National Safer Supply Community of Practice is funded by Health Canada's Substance Use and Addictions Program to facilitate and support the scale up of safer supply programs across Canada. It's a knowledge exchange and capacity building program. I'm going to talk a little bit about housekeeping for the event today, do an acknowledgement, and then hand it over to Dr. Jillian Kola and Dr. Andrea Serreta for the presentations. We will then do a question and answer period for our media and stakeholder attendees today. Following that, we will have a community of practice membership meeting. Everyone is welcome to stay and join in on that meeting, but that will give us a chance for our members to have a deeper discussion about the report. So just some quick housekeeping. Again, the purpose today is a media and stakeholder launch of the report. And we will have our community of practice meeting following this presentation. I'm very happy that we have Gabrielle with us today to do some the French translation of the event. Gabrielle, can I ask you to introduce yourself and explain the translation process?
Absolutely, thank you. So my name is Gabrielle. I'm offering a simultaneous translation into French. I'll just switch to French now to explain to French speakers how to access the simultaneous translation. Donc, je m'appelle Gabrielle. Aujourd'hui, je fais la traduction simultanée de la présentation. Pour accéder à la traduction simultanée, en fait, il faut cliquer sur le lien qui va être dans la boîte de clavardage qui vous mène vers un Google Doc, puis vous allez pouvoir suivre en direct à mesure que j'écris la traduction simultanée de la présentation d'aujourd'hui. Merci. Thank you.
Merci, Gabrielle. We also do have closed captioning enabled. If you'd like to use that feature, you will find that on the Zoom bar at the bottom of your screen. And there you will also find that there's a chat box where you're able to place comments, where you can introduce yourself, and we'll be monitoring that. If you have questions for the panelists, please put them into the question and answer box. You'll find both the chat and the question and answer at the bottom of in your Zoom toolbar. So please use the question and answer. You can ask the questions anytime during the presentations. We will address those questions in the question and answer period. And we ask for our community of practice members to hold on to your questions until our session after the media launch. I just want to make sure everyone is aware that this is being recorded, and we will be posting this on our website later on this afternoon tomorrow. If you have any technical difficulties, best bet, log off and then come back and try joining in again. Okay. Now I'd like us to start off this event in a good way, and to do so with a land acknowledgement. The London Intercommunity Health Centre is located on the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, and Attawandaron peoples, on lands connected with the London Township and Sombra Treaties of 1796 and the Dish with One Spoon Covenant Wampum. We would also like to recognize the 3 First Nations communities neighboring the city of Toronto, the Chippewas of the Thames First Nation, the Oneida Nation of the Thames, and Munsee Delaware Nation. With this, we respect the long-standing relationships that Indigenous nations have to this land, as they are the original caretakers. We come together today from different places across Turtle Island as people who live on treaty lands and unceded territories. We work in a sector whose goal is to address social harms, and we must recognize that the production of these harms come from the history of colonialism, and its enduring practices, institutions, and ways of thinking. Colonialism is with us today, and we must commit to working in ways that reshape these institutions and practices to repair harms, prevent future harms, and work towards a more inclusive and just future. Thank you very much. Please allow me to introduce Jillian Kola and Andrea Sereda and hand that over to them. Thank you for being here today.
Thank you to everyone who is here today. Could I have the next slide, Jillian? So I'm Dr. Andrea Street, and I'm the clinical lead of the Safer Opioid Supply program here at London Intercommunity Health Centre. And we are so excited to share our evaluation with you today and really talk with you about the impact that Safer Supply has had on people who use drugs here in London. So my role today is to take you through the background of how Safer Supply evolved in London, and also the underlying philosophies which our team here at the Health Centre applies to how we do this work every day. I'm going to be relatively brief, and then my colleague, Dr. Jillian Kola, will take the stage after me to get into the meat of the results of the evaluation. And we're really hoping that we're going to have a lively question and answer period at the end. Next slide. So the Safer Supply program in London is, as far as we know, the first take-home Safer Supply program in Canada. We have been joined by programs in Toronto and Ottawa and a diverse group of community health centres across Ontario and increasingly across Canada. But what is our origin story here at the Health Centre? Going back 6 years, the work in London started out of a desperate attempt to keep people alive. It was January of 2016, and I was really at my wit's end as a doctor. Fentanyl had been on the streets of London for 2 years by this time, and it had become the predominant street opioid by then. People were dying, and none of the traditional addiction medicine interventions available to me as a clinician at that time were helping. And I really felt powerless to help the people I cared for, and I watched so many of them die. But by serendipity around this time, I was also observing the results of one of our local in-hospital doctors. And this doctor managed the opioid withdrawal of people who use drugs with high doses of intravenous opioids while they were in hospital. Then this doctor, in some cases, would discharge people from hospital with prescriptions for oral hydromorphone tablets. And what I saw is that patients would do really well after they came out of the hospital with these prescriptions. People would avoid overdose, they'd avoid hospital admissions, they'd come to clinic to see me. And, you know, by and large, they were able to stop participating in criminalized behavior to pay for their street supply. But when the prescription from the hospital doctor ran out, people would turn back to the street supply of fentanyl again, and we would restart that cycle of withdrawal and illness that really defined their lives before entering hospital. So in 2016, I took a big leap, and I started to continue prescribing hydromorphone tablets for these patients after they left hospital. And the positive benefits we initially observed continued. So we kept going, and we added 5 patients here and 10 patients there. And really, before we knew it, we had this program where people just continued to get healthier and healthier. And after this, I went deep into a rabbit hole, learning about harm reduction and how it could help my patients. Next slide. And what I learned was that the history of harm reduction is this story of unprecedented grassroots organizing and action among people who use drugs. I learned that harm reduction, it means you need to center the voices of the people you are serving. And I learned that a lot of drug use can be linked to poverty, classism, colonialism, capitalism, structural violence, and racism. And I went on to learn that, you know, Canada is experiencing this deepening divide between haves and have-nots, and people who are finding themselves without the basics required for human existence, like housing or food or equitable health care, they can sometimes turn to drugs to help them cope with this extreme level of deprivation. So by listening and really listening to drug users, I learned how we have to move beyond these paradigms that really frame all drug use as problematic. And I realized we need to recognize this wide range of ways that drugs have been integral to the human experience throughout history. So then, you know, I went on and I sought to incorporate these lessons into my own medical practice. And I learned that at every stage of the development of harm reduction practices, people who use drugs have actually known and have been correct about what would save their lives. And, I also learned that everything that we currently take for granted in harm reduction in Canada, it was once illegal. And that drug users bore the burden, not just of surviving the problems of prohibition, but of creating and implementing the life-saving solutions that the rest of Canada was lagging in understanding. We can think back decades. I mean, needle exchange was illegal in the 80s when people were trying to save their friends from HIV. Safe injection sites, they're becoming more common and more accepted in Canada, but they were illegal until 2008. And up until then, drug users, they risked their own legal freedoms by operating, these underground safe injection sites to save the lives of their peers. And naloxone is on every street corner these days, but harm reduction activists had to beg and borrow naloxone for a decade before the government actually provided it. And even if we look at gold standard treatments for opioid use disorder, like methadone or buprenorphine, these still remain highly regulated and highly stigmatized. And, in our neighbors to the south in the US, these are even quasi-criminalized still. Finally, I learned it has taken health professionals and politicians years and sometimes decades to enact what drug users have been doing illegally for years. And I learned that when doctors and government adopted these solutions, we actually pretended that all of these life-saving actions were our ideas. Safe Supply has actually been on the lips of almost all drug user activists for years before I discovered what it was. And just like every other harm reduction intervention I've just described to you, people who use drugs knew what the antidote to fentanyl might be before doctors like myself had a clue. And with all of these lessons ruminating in my head, our team really decided early on that to grow Safer Supply in a way that recognized this legacy of drug users, we really needed to focus on listening to the people we serve, focus more on listening than telling. And we worked really hard to make sure that we were growing the program with drug users really centered as experts and equals to our team. As we move through the years, getting experience under our belt, my team and I, we continue to learn lessons. We watched this overdose crisis decimate communities and leave grieving families and friends in its wake. We shared in this moral trauma that comes from having governments and physicians and systems that are unwilling to act to save these lives. And we came to understand that the systems that uphold prohibition in Canada that have resulted in people who use drugs suffering, this burden of stigma, inadequate and often negligent medical care, criminalization and marginalization for the past 100 years. So our team focused on taking the narrative you see on this slide from they talk, we die to we act and we live. And by trying to change the paradigms of how we interact with people who use drugs. And the successes that we saw early on in Safe Supply and that you're going to hear more about today, it demonstrated to our team that for so many people, many if not most of the grievous harms of criminalized drug use are actually harms created and imposed by the medical system in the state. So to take steps to get ahead of this crisis, instead of always being 10 steps or thousands of bodies behind, we need to do things differently. And Safe Supply is part of that. So I'm really happy that we're now in a position today to share evidence about the positive impacts we've been seeing Safe Supply having. And we hope that the evidence that you hear today being generated by Safe Supply programs across the entire country is going to show our governments why we need to expand the range of therapeutic options available. And we hope to demonstrate the efficacy of these programs so we can move beyond having more than just short-term funding for a handful of pilot Safe Supply programs. Safe Supply is about so much more than prescribing drugs. It's about building relationships with people who have been pushed to those margins. It's about ensuring medical professionals actually provide comprehensive care to people who use drugs. And it's about pushing our government to recognize and rescind the laws that are criminalizing drug use and the people who use them. Thank you for coming to listen to us today. With that, I'll turn the floor over to Dr. Jillian Kola.
Thanks so much, Andrea. And it's my pleasure to be here today to present some of the results from the evaluation that we conducted of the Safer Supply program at London Intercommunity Health Centre. So my name is Gillian Cola. I'm a public health researcher, and I worked on this evaluation as an external consultant with the team at London Intercommunity Health Centre. As Andrea mentioned, the Safer Supply program started in 2016 at London Intercommunity Health and then was expanded in 2020 when SUAP funding was received from Health Canada. And so we got together and we started to put together a community-based approach to how to conduct an internal program evaluation that would talk a little bit about some of the impacts that this program was having on people. So a couple of things that I want to get started just emphasizing right from the get-go. The program is very much a harm reduction approach to addressing substance use, and the model of care at London Intercommunity Health for their Safer Opioid Supply program is very much a primary care model where wraparound services are then offered to all of the patients who are part of the program from the interdisciplinary team at the center. This includes access to care facilitators, outreach workers, system navigators, nurses, nurse practitioners, as well as physicians. And it's important to note that all of the patients in the Safer Opioid Supply program become patients of the family health team, of the primary care practice at the Intercommunity Health Centre. So they get access to comprehensive medical care as well as Safer Opioid Supply. And Safer Opioid Supply here refers very much to the prescription of pharmaceutical opioids that's individualized to the individual and to their needs. And I think it's also important to note that most of the people who are part of the program have had very comprehensive health services, or they've had a lot of interactions with the addiction treatment system prior to this program. That was one of the things that we heard a lot from people is about their previous experiences accessing and not having very much success on methadone treatment, buprenorphine treatment, and other forms of addiction treatment. So in terms of our evaluation goals, this is very much an internal program evaluation. We wanted to center the voices and the experiences of the clients in the program to figure out what was working well for them in the program so that the program could continue to adapt and improve the services that it's offering. So we explored client and staff perspectives on what was working well. We really, really pushed to have client and staffs talk to us as well about what could be improved in the program, where they saw the issues happening or the different pain points. And we made recommendations at the end of the evaluation for both the program as well as for the larger health system. And I have to tell you, I wasn't expecting to make very many recommendations around the health system at the outset, but these were very, very prominent in the narratives of clients that we spoke to. And so that's why they were included. This is a mixed methods evaluation. So we used both surveys with people who were starting Safer Supply for the first time, as well as with a group of Safer Supply clients who had been on the program for at least 6 months. You'll see some of those results today. We also did several focus groups with clients, with staff, as well as with people who were on the wait list for the Safer Supply program, because we wanted to see from their perspective why they were interested in the program, as well as the barriers that they saw to access. Now, I just want to note that right now we're in a really interesting moment because as Safer Supply programs have been scaling up across Canada as well as in Ontario, there's a number of different research projects that are ongoing. So our program evaluation is actually very limited and humble in a sense. We wanted to very much just provide information on what the program was doing in the first year and a half after it received the funding from SUAP. But there is a lot of very interesting research that's going on right now around Safer Supply programs, both within Ontario as well as in Canada. I've listed a couple of the studies that are going on right now, both involving London Intercommunity Health clients and patients, as well as some of the broader research that's happening on Safer Supply in Ontario, as well as nationally. And I think it's just important to note that I think we're going to go into a period in the next little while where we'll start to get some really strong research evidence on these programs, and that this will start to answer some key questions we've got about how the programs are functioning, the impacts they're having on people's risk of overdose, as well as other health outcomes and indicators. So to get started a little bit on the program statistics, April 1st, 2020, the date you can see on the left of your screen is the date that the SUAP funding started. At that point, there was 112 clients in the program. There has been 152 new clients enrolled in the year and a half. That was the period of our evaluation here. And there's currently, well, as of September 30th, 2021, there was 248 clients within the Safer Supply program at London Intercommunity Health. 16 people are no longer enrolled in the program, which leads to an overall retention rate of 94%, which is for programs in this area that are dealing with a population of people who use substances and have some problematic patterns of substance use in particular. This is a very strong retention rate overall. And you can see in the purple on the screen the number of encounters with the healthcare and the social care team on site. There was quite 20,000 encounters with the healthcare team, 2,000 encounters with the social care team. So it's a very well used program by the people who are enrolled in it. Speaking of the program impacts, it was very, very touching to me to ask clients to tell me about the program and the way it had impacted their lives. We overwhelmingly heard from people just how much the program was having positive impacts on this. You can see this in the first quote on the slide where people say, it's done nothing but good for me. I've got my family. I've been housed for the first time in 10 years. I'm volunteering. I'm just doing things I didn't care about, had no motivation to do before. The second quote speaks about how they have interests now and they've had time to find things that they like to do. And so this was very, very prominent. People felt that the program was saving their lives. They spoke overwhelmingly about how kind the staff were to them and helping them to meet their needs. And people really spoke about how it gave them, being a part of this program, gave them the chance to actually focus on different aspects of their lives that they hadn't had a chance to focus on in a long time. Looking at some of our survey results, when we compare what people were telling us about their use of unregulated opioids, so opioids from the street-based markets, either fentanyl or other opioids not prescribed to them, you can see very, very high rates among clients who are starting Safer Supply of injecting as well as smoking or snorting fentanyl. And then you see quite a dramatic drop for current Safer Supply clients in terms of their use of the unregulated drug supply. The second graph on the right speaks about daily fentanyl injection or daily smoking of fentanyl. And here again, you can see quite dramatic reductions in people's use of fentanyl, their daily use of fentanyl when they are on the program. One thing I want to highlight here, and I'll come back a little bit to this in the end of the evaluation, is the high rates of smoking. As fentanyl has come across Canada, we're seeing more and more that people are smoking fentanyl a lot more, and that there's a lot of mixed drug use that people are injecting as well as smoking fentanyl. And I think that this is something that we need to ensure that we're adapting to within both our harm reduction and Safer Supply programs to ensure that we're meeting people's needs. In Ontario, we currently don't have a smokable option for opioids to prescribe to people. When we asked about people's fentanyl use, people talked about how in the first quote you can see fentanyl is like doing Russian roulette. You don't know when your time's up. This was really a very prominent theme. In general, people had lost a lot of members of their communities to overdose, and they were worried that they were going to overdose as well. And it was one of the main reasons that people wanted to be part of the program, and it was one of the main things that they felt that the program was helping them with was in reducing their overdose risk. The other main impact on people's use, you see in the second quote where this person talks about how they had been spending $500 to $600 a day on fentanyl, and now that they're part of the Safer Supply program, they're only using 1 point of fentanyl a day, so they're using dramatically less. And this means that they're spending quite a bit less money and that they also have more time to be spending on other pursuits like was in the previous slide. Now, one finding that we didn't expect, because this is a harm reduction program, the goal of this program is not to get people to stop injecting if they don't want to. It's very much in line with people's own personal goals. But even without having a focus on reducing the amount of injection drug use, we found that on the surveys, 35% of the current clients stated that they were no longer injecting drugs at all and were either completely taking their Safer Supply orally or smoking. And this was a very, very strong impact. And again, I think that it speaks to the different ways in which people are using the options available to them, and about how even with a harm reduction program without a goal of reducing injection, when people are able to actually make their own goals and figure out what works for them, they'll move in the direction that works the best for them. In terms of overdose, this is a very, very important slide, a very important finding, because one of the major aspects of safer supply programs, the goal is to reduce risk of overdose. Here we see, when we ask people about the overdoses that they had experienced in the last 6 months, we see quite a striking decline in the number of overdoses among people starting safer supply, going from 60% down to 23% in the past 6 months among current clients, as well as overdose in the last month. We see that only 11% of current safer supply clients had reported an overdose in the last month, compared to 33% of people starting the program. And the reasons why, when we asked people about why they thought their overdose risk was reduced, was, as this person says, this is you putting me at a safe dose so that I'm not going to go and overdose on whatever. People really appreciated knowing that they were getting a standard dose that they understood the potency of when they were as part of the safer supply program, compared to when they were injecting fentanyl, which of course there's a highly volatile drug market right now. The potency is very varied between different points of fentanyl, which really very much contributes to the overdose risk. Oh, sorry, I think I jumped too far. Okay, homelessness. We asked in the surveys about some of the social determinants of health, some social indicators. And when I'm speaking these days about the current moment that we're in, we're often talking about how there's dual public health emergencies going on right now, of COVID and of the overdose crisis, which of course was there before COVID. I've started speaking about the third public health emergency that we're facing that we don't often talk about. And that's the emergency of lack of affordable housing and homelessness that people are facing. And I think that you see that represented quite dramatically in this slide, where 73% of people coming into the program had experienced homelessness in the previous 6 months, as well as 72% of current safer supply clients. Now, because London's program is very much focused on helping to provide health services to a community that is street involved, this is somewhat not surprising, but I think it's very, very important to highlight just how much the lack of affordable housing is impacting people. I think that we can throw as many health services and social services to people as we want. However, if people are living in a tent when it's -25 outside and 40 centimeters of snow just fell on your tent, there is a limit to what health services can do to improve your health when you're in that living with that kind of extreme deprivation. This is reflected as well in the slide around the difficulty finding enough food in the last 6 months, where safer supply did make an impact on people's ability to find food, but we still see very, very high levels of material deprivation and difficulties in finding enough food. This is partly reflected in the results. When we asked people about the impacts, again, people talked so much about how safer supply was allowing them to take better care of themselves, which you can see on this slide. There was a whole side conversation in one of our focus groups where people were talking about how much weight they'd gained, about how they hadn't been able to gain weight for years. And then they started safer supply, started to feel some stability in their lives, and were gaining a lot of weight, as you can see in that second quote there. People also spoke about improved relationships with family members. This was unprovoked. I hadn't asked directly about this. And this was another topic where people came and started talking about how much they had a better connection to family members, grandkids than they had before, or than they'd had in several years, as you can see in the second quote there. And so really how it's enhancing their social functioning and their social lives as well. Involvement in criminal activities. So we asked people some survey questions as well as in the focus group about their involvement in criminal activities to either pay for or get drugs. And here you can see that coming into the program, 86% of people reported that they had engaged in criminal activities. And this dropped to 38% among current safer supply clients, with 44% of people in the graph on the right reporting that they had no involvement in criminal activities whatsoever since starting safer supply. And I think that this really speaks to, the ways in which the ways in which people with fentanyl, because it has such a short duration of action, people are having to use much more frequently than they did with heroin. And here we can hear somebody speaking about how they say they haven't broken the law since they've been on the Safer Supply program. They haven't robbed anybody. People aren't afraid of me right now. This program's really helped in that way. I haven't been to jail and my record's looking better. So it seems like Safer Supply is really having strong impacts on people in letting them not only develop other activities and social interactions in their communities, but in very much reducing their involvement with criminal activities as well as with the criminal legal system. We also saw decreased involvement in sex work among people. I think I skipped a slide. Sorry. Oh, here we go. We saw decreased involvement in sex work among people participating in this evaluation, with 50% of people saying that they had been involved in sex work to pay for drugs in the 6 months prior to the study. Among current SOS clients, that dropped to 20%. And again, we see 21% of people reporting no involvement in sex work since starting Safer Supply, with 18% saying that they have decreased their involvement since starting Safer Supply. And here again, we can hear from one of the participants in the program who's talking about how they have been able to reduce their involvement in sex work, as well as, again, a similar theme, reduce their involvement with the criminal legal system because of that. And this person also thinks very much that it's responsible for having saved their life. Health services use. So I think it's important to really emphasize here that people who are coming into the Safer Supply program tend to be what we call people with high acuity. They have a very high number of health needs, and often these are very, very complex needs. You can see this partly in the fact that 77% of people had visited an emergency room in the 6 months prior to starting the program. This drops quite dramatically to 45% among current clients. And if we look at hospitalization numbers, we see a similar trend where 36% of people had been hospitalized for at least one night in the 6 months prior to starting the program, where that was only 11% for current clients. As I mentioned, very high acuity, people have a lot of complex health needs, very complex health conditions, and they have histories, very significant histories of both physical trauma as well as chronic pain. The first person here, you can see where they're talking about they've had 1 billion blood infections and abscesses. And the second person, who was actually one of the people in the group on the wait list, is talking about here how they had a very significant spinal injury and they just want to get pain managed. And they just need to have something. They're sick of being in pain and how they can't get a doctor, which really speaks as well, I think, to the deficits across the healthcare system in caring for people with really complex health needs. In terms of physical health, I was quite shocked by this slide and by the findings on this one, where people, 55% of people who are coming into the program said that rated their health as either very poor or poor. This one, I just found it very, very sad to see the level at which people's physical health was an issue for them. Fortunately, current Safer Supply clients, we start to see some movement in a positive direction where more people are saying that their health is either okay or good or excellent. This was reflected as well in the qualitative findings, where people were talking very, very strongly about how they didn't think that they'd be here right now or feeling as healthy as they do, and how this program allowed them to get their hepatitis C taken care of. In terms of mental health impacts, again, a very striking and sad finding that 60% of people rate their mental health as either very poor or poor. And we found that there was a positive trend again in this direction, but less striking than with the physical health. And I think that this speaks to how this is also a population who have really, really strong needs for social supports and social determinants of health supports, in addition to physical health care, or health care for their physical needs. One of the benefits of the Safer Supply program and the funding that came from SUAP was the ability to actually provide wraparound care for people. So having, and this is an interesting quote because this person is basically talking about how there's a little bit of a patchwork going on prior to the Safer Supply program. And one of the benefits of the program in their view was it's all little blocks, everybody's taking a little piece of you, but no one's putting you all together into one until you get into this program. And about how there was really strong impacts for them in terms of being on the Safer Supply program, in terms of having all of these wraparound services and care available. Now, in this last section, I'm going to really quickly talk about some of the challenges that we identified in the evaluation. So I think that the major challenge that we identified was the high level of demand for the program. People who were both people on the wait list as well as clients talked about how there was not enough prescribers, that there was major capacity issues. You can see this very, very strikingly in the second quote, where the person talks about how it took them 2 years to get on the program. And so this was the major capacity issues here were the major thing that we identified as an issue in the program. We also identified the need for expansion of medications available. And this is really, really twofold here. Part of it is about how people need a wider range of medication options in order to be able to meet the needs. I think this is particularly an issue when it comes to the need for smokable opioids for people who are smoking fentanyl. And so we need a better array of options. People still speak very fondly of heroin and would very much like a return to heroin, a regulated source of heroin. Pharmaceutical sources of heroin do exist. They're very well used in heroin-assisted treatment programs in Europe, but we have very strong regulatory barriers at both the federal and provincial level in Canada to be able to offer heroin as one of the options, and people really were talking about how that was an issue. The second quote here speaks about, is from somebody who's still using fentanyl occasionally from the street supply, and when asked why they were still using fentanyl, they said, "I like it better, I get a better buzz from it." So they were using their hydromorphone, it was meeting their needs, but they still occasionally enjoyed using some fentanyl for the street supply because of the potent high from it. And so I think that this is very important feedback for safer supply programs. I think it also speaks to how, now that we've had several years of high potency fentanyl available in the street supply, people have become very accustomed to that. And we do have to start thinking about options for fentanyl and pharmaceutical fentanyl for people who have super high tolerances and who really become accustomed to the potency of the fentanyl and the buzz from it. Another major finding in the study was around negative experiences with other healthcare providers. And this came out very interestingly because it wasn't necessarily that people were talking about experiencing stigma and discrimination, although they were talking about that. But here they would talk about how when they were interacting with other forms of the healthcare system, that they would hear a lot about the prescriber who was prescribing Safer Supply at London Intercommunity Health. And they would say that they don't agree with what Dr. Sereda is doing. In this first quote, the person says, "It's like, you guys don't understand what we go through on the streets. You know what I mean? If she wasn't helping me, I'd be in jail right now. You know what I mean?" And I think this is particularly key because people, they really, really felt judged by statements like that. And more than anything, they felt like it communicated that the healthcare providers didn't understand their realities and didn't understand how this was a program that was literally saving their lives. And I think that this has real impacts on the therapeutic alliance that's necessary for healthcare providers to build, particularly with populations experiencing high levels of marginalization, like people who use drugs. We know there's a lot of stigma and discrimination towards people who use drugs within the healthcare system. And I think that we really need to have strong conversations about how we can address this because it's very much interfering with people's ability to get healthcare within hospitals and within other parts of the healthcare system. This also led to major issues in terms of continuity of care during hospital admissions for people who needed admission to the hospital. And here you can see a collection of quotes from the first one where the person said, "I had major surgery. They didn't agree with the program. So I went through withdrawals right after major surgery." So their needs for pain control were not being met due to the prescribers in the hospital and their judgment about the program. People also very much felt like they were being classified as junkies when they were in the hospital. And a staff member talked about how they were attempting to provide continuity of care when people needed to be hospitalized, but they had a lot of very significant difficulties when doing that, and that this was a major issue that they were continuing to face. Now, I just want to say a couple of words about the sharing and selling of medications, which is often known as diversion. And I think it's an important topic to broach. We asked a lot of questions about diversion, about selling and sharing of medications. And we heard from a lot of people something similar to in the first quote here, where this person says, "I'm very greedy with my stuff. It's very rare that I'll share my meds with anybody. And I'm like, you know what? I'm sorry, I need this." People, I think, really do appreciate and are using using the medications. And there is occasionally some sharing and selling that's going on. Again, it's driven, I think, by very much systemic and structural factors. And this second quote speaks to that. When the person says, if somebody's fentanyl intake is very, very high and they need 0.5 gram of fentanyl, then they might sell part of their script to get as much fentanyl as they can. So again, I think that we really, really need to dig down into the systemic and structural issue that's going on here, which is that we need to be able to provide people with the medications that are going to meet their needs and meet their tolerances if we're going to be able to really address the crisis that we're having right now. I think the other thing that's important in terms of sharing and selling of medications is that most people spoke about how they would sell or they would share with family members and friends. And this quote really, really speaks to that. This person's actually talking about who should be moved to the top of the wait list for the program. But they say you can't be on it and not expect to be splitting with your spouse. That's just common sense. You're not going to be sitting there doing your dope and watching your spouse sick. That's not happening. And here again, this is speaking to the care that drug users have for others within their communities that I think we don't focus on very often. And I think that we really, really need to ensure, again, this is a structural issue of not having enough program capacity or access for all the people who need it. Just a couple of quick final words. One of the things that came out in the evaluation was that there was a strong need for an on-site supervised consumption site at London Intercommunity Health Centre. The first quote here is speaking about the current supervised consumption site in town, which is run by another organization. They're clearly doing an excellent job. People were speaking about how they feel comfortable there. They feel like nothing's going to happen to me. They feel like it's a safe place. However, we know from other research that people don't tend to travel very far to use supervised consumption sites. And in the second and longer quote here, people are talking about how they gather in an outdoor area close to London Intercommunity Health to use together because they actually have a feeling of safety because there's other people around who can revive them if they were to have an overdose. But I think this really, really speaks to the need to also ensure that this service is available inside at London Intercommunity Health for clients of the health centre. I just want to spend a really quick moment talking about staffing. The participants were overwhelmingly talking about how they appreciated the care that staff had for them and towards them, but they spoke very much in terms of the focus group with staff about how they feel like they're running people off their feet. I think we really have to emphasize here how much the pandemic happening during the overdose crisis, as well as the continuing issues with affordable housing and the affordable housing crisis, means that staff are very, very exhausted. They've really been pulling double and triple duty for several years now. And so I just wanted to highlight that because that came through very clearly within the evaluation. Also, people were talking about the importance of peer workers and ensuring that there's a lot of people with lived experience as part of staff. Finally, in terms of recommendations, I'm not going to spend too much time here because I covered over most of these in the challenges. Increasing the capacity of programs, the number of prescribers, not just within London Intercommunity Health, but also in other agencies in London is very necessary. There's also a need to provide clear information about waitlist and triage criteria to people on the waitlist. A need to continue to expand wraparound services because there is very much these social issues that need to be addressed for people. Providing accompaniment for pharmacy pickups for some people, they express that they would really appreciate that. And advocating for program expansion and increased pharmaceutical options and medications to address sharing and selling of medications. As well, in terms of systems level recommendations, here it very much comes down to two separate issues. The first is the need for a larger amount of medications available to people. And the second is around addressing stigma and discrimination within the healthcare system and the need to provide continuity of care when people are being hospitalized. So thank you very much. I hope that that was informative, and I'm very, very happy, and I'm sure that Andrea is as well, to answer any questions that you might have about the presentation today.
Thanks so much, Jillian and Andrea. Amazing findings, and we have a lot of questions that have come through. We are prioritizing questions from our stakeholder and media attendees today. I invite our community of practice members who are here to stay after so we can have a more in-depth discussion about the findings and recommendations and next steps. So let's jump in. We have some questions that came up through the chat and also in our question and answers. We're still opening for questions there. A methodology kind of question, Jillian, to start off with. Claire asks, did you do baseline and 6-month surveys with all clients, or are you comparing 2 different cohorts, new clients compared to clients who've been in the program for 6 months?
That's a very good question. Thank you, Claire. Yes, so this was 2 separate populations that were, it's basically a point in time look at the 2 of them. So this isn't a longitudinal look at the same group of people and their change through time. So it's important to note that we can't really determine any kind of causal implications here. This was very much a convenience sample of people who were available and willing to answer the surveys during the period in the summer and early fall when we were doing the follow-up surveys with people. We also had a somewhat low response rate, particularly for the group of new people who were coming into the program, because at that point, due to the COVID pandemic and program capacity issues, there weren't a large number of people coming into the program. So we are going to be continuing to do this survey at 6-month intervals. So we'll have more data through time to increase it. And there's also a bit more information in the larger report on the methodology that we used.
Thanks, Jillian. Sawyer asks, what would you say are the key takeaways from the program? Keeping in mind the program's not supposed to get people off of drugs, are there any people who this program has helped stop using drugs? And also, Sawyer, you ask, is there a media release summarizing the findings? We do have the summary report on, as well as the full report, but the summary report up on our websites. We'll plop that into the chat. Also, through our community practice social media, we have some key takeaway points there. So Andrea and Jillian, would you like to address the middle question there? Keeping in mind the program's not supposed to get people off of drugs, are there any people who this program has helped stop using drugs?
So the answer is complicated always. You really have to consider what using drugs means in any kind of context, right? So we know that we're helping people use drugs in a safer way, and we can see that with the reduction in injection drug use and the reduction of fentanyl use. And we do have many people who only use their prescription for hydromorphone. And so when we look at it that way, when people's lives are stable, they're using their medications as prescribed, they're gaining positive health benefits from that, but they still have their prescription. This becomes like any other chronic medical condition we would manage in primary care. And so people can be considered absolutely equivalent to those who are taking their medications every day for diabetes or so forth. So it's a yes, but, and another place where we need to change our thinking around this.
And if I could just add to that, I think one of the key takeaways from this program is that this is a group of people who have tried multiple different forms of treatment and healthcare prior to coming into the Safer Supply program. So this is a group of people who, when we ask them about what they've tried before, they've tried methadone, they've tried buprenorphine, they've tried multiple times, often over several decades. They've tried inpatient rehabilitation options. And so this is a group of people who most of the standard medical treatments that we have available for them up until now have really not worked for. And this does seem to be working for them, both in terms of people reporting the positive health aspects for them, as well as the diminishments in their use of street acquired opioids that they're reporting. So I think that it's really important to actually note here that this is a group of folks who at some level we kind of had been like, sorry, we have nothing for you up until this type of program had started, and who are now actually seeing strong benefits. And I think that for me, that's one of the key takeaways for sure.
Thank you both. We've got a lot of questions. I just want to say that for questions we're unable to answer, we are keeping track of all the questions and we will follow up with answers either directly to you if we have your name and email address. And if not, we will send, we'll also send a collective document with all the questions with answers to our to all the attendees where we have email addresses. So the next question I'd like to bring up to Andrea, there was a question about when Jillian shared the results of the stats around program retention. Jillian, I believe you said around 94%. There was a question posed regarding why do people leave? Can you address that, please, Andrea?
So I think in the data that Jillian presented, there were 16 people who had left the program at this point, showing that 94% retention. And the answers are complicated, again, they all are. But some people have moved into long-term institutional care. So whether that's a longer stay in jail or whether that's a longer stay in hospital. Some people have moved to other cities and are now supported by other programs. Some people have left, a small number have left to go on to other treatment modalities. And we have lost some people to death, unfortunately, during the program. We have lost some people to overdose from fentanyl, and we have lost some from infectious complications. Those stories, again, are in depth and complicated and in the minority.
And I should just add as well that some of the other research that's ongoing, this particular evaluation didn't look at patient level outcomes. One of these studies that's happening is a chart review, which has a higher level of research ethics standards around it. But we're going to be looking at some of those outcomes in the chart review data as well as looking a little bit more in depth at health systems utilization for different health needs like infectious complications and overdose. And so this is an area where I think that some of the other research that's upcoming is going to shed a lot of light on some of these trajectories that people have as well.
Amazing. Jesse asks, it seems people are most concerned that individuals will continue to use unregulated substances with their prescription. Dr. Sereda, is this a dose problem? What other substances would you like to see on the formulary here in Canada?
That's an excellent question. So the answer is yes, it is sometimes a dose problem. Just addressing about people who use ongoing street supply of fentanyl or other drugs. As Jillian alluded to in the middle of the presentation, many people will use their hydromorphone prescription to meet their withdrawal and ongoing opioid needs. Sometimes people like a hit of fentanyl because it gives them that extra buzz, it gives them something that they're enjoying. No different than you and I having a glass of red wine on the weekend. But the dosing is interesting, and we certainly saw a rapid inflection upwards in people's opioid tolerance right around the beginning of the pandemic in March 2020. We saw people double, triple, quadruple what people in the cohort before that time were experiencing. And so when people get up to very high levels of fentanyl use, above a gram, above 2 grams, half a ball, yes, it is hard to meet their needs with hydromorphone alone. And we've been strategizing around that. We have long-acting opioid backbones, as we call them, on many hydromorphone prescriptions. And that, again, helps with that tolerance issue. But part of the advocacy we're doing is trying to get other medications on the formulary that we can incorporate into a safer supply approach, whether that's diacetylmorphine, which is heroin, whether that's actually liquid injectable fentanyl or smokable products. We're exploring all of this, and that would help with people who have ongoing needs for illicit use.
Thanks, Andrea. We've got two similar questions here. I'm curious to see I'm curious to know how you see yourselves working with conventional addictions medicine. And then also, do you have suggestions for how to approach addictions medicine physicians that seem to have a misunderstanding of safe supply, have misaligned values, undermine harm reduction, or have conflicts of interest, such as funding, kickbacks? Or are some addictions med docs just never going to, in quotes, get it?
I mean, it's our hope that we work together with our traditional addiction medicine colleagues hand in hand. I think we're all trying to save the same lives here and address the same problem. And I think we need to focus on that. We also consider safer supply to be in a spectrum of all of these options. We have never once advocated that safe supply needs to replace more traditional means like methadone or Suboxone, which is buprenorphine. We think every individual is unique, and people need that wide array. Some people need, 12-step abstinence-based approaches. Some people need residential treatment. Some people succeed on methadone. Some people succeed on Suboxone. And some people succeed on Safer Supply. And so this entire array needs to be offered to everyone who needs it in a way that people can actually access it, because that is part of the problem, big part of the problem. And we need to consider that, you know, this is not a one size fits all solution. And I think our progressive addiction medicine colleagues really agree with that. And we collaborate and work with them on an ongoing basis. I think the second question, and I don't want to harp on addiction medicine physicians exclusively, because I think the second part of the question actually speaks to people's frustration with the system. And I think medicine evolves. Society evolves. Some doctors, whether they're practicing in addiction medicine or diabetes care, may have views that were based on what they learned 10 and 20 years ago. And just like everybody else, sometimes we get stuck in our ways and have to learn new things. So I'm going to give those folks the benefit of the doubt, and we're going to try to continue all of our educational offerings to make sure that everybody understands what we're trying to achieve.
So if I may, I'm going to give them a little bit less of a benefit of the doubt. I'm a co-author on a report that was released here in Ontario earlier this week that was looking at healthcare systems utilization among people who had died of an overdose in Ontario during the pandemic. And we found very high rates of health services use among people who were dying of overdose. 25% of people had had a healthcare encounter in the week before their death, 50% in the month before their death. I think there's often a misconception that access is the issue. And we're seeing actually in some of the research that we have that people are actually trying to access healthcare to meet their needs. The problem is that we do not have healthcare systems that are well adapted to meeting the needs of people who use drugs, particularly of people who wish to continue using drugs, or people who are experiencing extreme social vulnerability. And I think that we really need an across the board whole systems approach. Number one, to ensuring that people get adequate anti-stigma training around substance use, that they get training that actually can help them address when they see people with substance use issues, whether it's in a diabetes clinic or in the emergency department. So I think that that's one really, really key part of this. The second, though, is that we actually need all of the available options right now. We're in the middle of an absolute crisis of an overdose death that has gotten so much worse during the pandemic, and yet we feel like it's like moving molasses speed. Nothing is happening. We have small pilot programs that are trying to make a difference. We have addiction medicine doctors who've started addiction consult services in hospitals in their free time in order to try to improve the care that people are being offered. We have these really small groups of people who are trying so hard and frankly burning themselves out doing it, when what we actually need is comprehensive leadership at both the federal and provincial level, as well as within municipalities, to actually come together and say, no, this infighting is ridiculous. We need to actually make sure that all doors are the right doors, that people get access to the individualized care that they need, and that we start accepting that the range of care options for people is going to be larger than what we've traditionally accepted within very strict abstinence-based philosophies. And we really need to do that quickly because we are losing so many lives.
We have time for one more question, and I think it actually tags into what you were talking about there, Jillian, which is a question from Brenna. Much appreciation for all the great work that's happening. One of my questions is about primary care. Dr. Serrata's program is the only one in the city where there's access to wraparound and primary care at the same time as OAT, harm reduction, safe supply. What % of the benefits of this program is related to not the opioid prescription per se, but to the other services? Should all methadone Suboxone clinics offer primary care and wraparound services?
So this is an absolutely great question, and it really is the crux of the issue here. It is, I think it's both. And unfortunately, the evaluation methods we used don't have the ability to differentiate what portion is the medication options that people are being given and what portion is low barrier access to primary care as well as social supports. So I think that it's both of those things, to be honest with you. And I think that you're totally right in terms of, yes, every methadone and Suboxone clinic should also be offering primary care as well as social supports. They should be funded to do this well. I think that I will get into a larger question about how we fund different programs within our health system, but this is obviously a major issue. So I think that we need to make sure that we do have these comprehensive services available. And I'll say one more thing about funding. We often very, very heavily fund the hospital-based care, emergency departments. We don't fund community-based care, and especially not social supports to the extent that are needed. And this is really where we need to be ensuring that we do have these supports available for people and easy to access. And I think that that would go a long way to addressing some of the issues that we're facing.
And just in our last moment, I want to elaborate on what Jillian was just saying. I think it's a really complicated, I keep saying complicated, everything's complicated in my life. Some of our critics have actually used the presence of primary care within Safer Supply to actually criticize the approach, and to say that actually it's the primary care that's causing the benefit and it's not the safe supply approach. And really, if we just did the primary care with, methadone or something, everything would be better. And critics have taken this all the way to the college against me. And the answer is yes, primary care is making a hell of a difference for safe supply patients. But why is that a problem? We're taking, this is in the last part of my segment, we are taking people who we've excluded from healthcare. We're giving them a reason to trust. We're giving them what they say they need because we're actually listening to our patients. And then that helps them to trust us so we can do the rest of it. It's hand in hand. It's not one or the other. They go together, and it just comes all together in terms of dismantling the barriers to people who use drugs in our traditional healthcare system.
Amazing. Thank you. One thing we have not had time to talk about, and I hope we can all move into our community practice meeting and talk about the role of people who use drugs in this program. We do have a couple of questions asking about that. So for those of you who are interested, please stay, let's talk. Also some questions about how we can do some advocacy around expanding options within the Ontario formulary. So for those of you who have joined us from the media stakeholders, for the launch. Thank you so much for taking the time to be here and hear these important findings today. And I do invite you to carry on and stay with us if you would like. But thank you, Jillian. Thank you, Andrea. Thank you so much, Gabrielle. And also to all those who have made this session possible. Thank you. We will be posting the recording of the webinar this evening, tomorrow. So stay tuned. We'll send out an email saying that it is on the website. The report you can find on the LIHC website, also on our National Safer Supply Community Practice website. Yeah, okay. Thank you. For those of you who are leaving us, thank you for being here, and goodbye for now. And for those of you who would like to stay on, we'll just pause for a moment and switch gears. I'm also happy to, we can't just switch from webinar to meeting, unfortunately. But if there's somebody who would like to, if you'd like to continue to use the Q&A for questions, and if we need to move into opening up for people to actually speak, we can figure that out as well.
Can I just say thank you to everybody who's putting questions and comments in the chat? I'm just trying to read through now because I didn't get to actually see it while I was presenting. And I really appreciate the interaction. It's hard when you're doing Zoom presentations and you feel like you're speaking out into the void. And so I very much look forward to the day that we can do in-person presentations and actually have in-person conversations about these things again, hopefully soon. But I just want to say that I very much appreciate the comments, and hopefully we'll get a chance to address some of these in this next little bit, but it's very nice to have feedback as I sit here in my little box on the screen.
I was trying to answer some of the questions in our Q&A as we were going, and Rebecca's like, no, save it for the community of practice session, which we're doing now. So I would love to get into the itty gritty of questions and there.
Let's do that. I would love, because we do have some questions asking about the role of people who use drugs, the role of clients. We do have a couple of comments, questions, some coming to me individually. So can we start there? Because that's such an integral part and something that really differentiates the LIHC program and some other amazing programs out there from other programs. Can you talk a little bit about that, Jillian and Andrea?
Sorry, Andrea's, okay, why don't I start because Andrea seems like she's got someone coming into her office. It's okay. I had my kids' school calling me repeatedly while I was presenting. Fun times as we multitask around everything. So I'll speak a little bit about how we integrated people who use drugs in the evaluation process. So I try my best always to do community-based research. So we actually put together a community advisory at London Intercommunity Health composed of people who were clients of the Safer Supply program. They were very, very helpful in terms of helping us to figure out some of the objectives of the evaluation and the lines of questioning we wanted to pursue. And then one of the things that we did is when we finished the draft of the report in November, I came back to London Intercommunity Health and I actually did another set of groups with the community advisory because I think that it's very important to bring the results and the findings back to the clients themselves. I sometimes like to call it the bullshit test, where you actually present the findings back to people and you see whether or not they resonate or whether they call bullshit on you and say, no, that doesn't reflect it at all. And so we had a really great discussion and the community advisory team has been really, really pivotal in that work and in helping, they're also helping me right now to figure out the next steps of our program evaluation, because this was just one of several different iterations that we're going to be looking at in the next little while. So that was a bit how we did it on as part of the evaluation process.
Andrea, anything else to add there?
This is where I make my joke about 2 years into Zoom and I still don't unmute myself. No, thank you, Jillian. I think that was a great answer. Great.
Just looking through some of the questions here, there's so many questions we haven't answered. So one was, there's two questions that are related to parenting. One was, I'm wondering if you engage with patients who are pregnant. And the second question was, are women at risk of losing their children if they come forward as drug users?
So number one, heck yes. We've actually prioritized women who are pregnant and dependent on street-based fentanyl into the program. And so we've actually gained a lot of experience with women moving through their pregnancy. The answer to the second question, it can be yes and no. I would say certainly it's a concern of most women coming into the program. They're afraid if, they're associated with us or identified that they're on Safer Supply, that could impact their ability to parent in the future. I'd like to say that actually that has not been the case. We've worked really closely with our CAS colleagues. We've really been able to demonstrate how women have stabilized their lives in a way that can allow them to parent. And so I think there's been a lot of positive benefits there. I think there's a lot of stigma and discrimination that is still around for women who are pregnant and using drugs or women who are parenting and using drugs. And that's an enormous hill that we still need to continue to battle on.
Thank you. There's so many questions. There's so many great questions. So let me just look through. There's a number of questions that relate to advocacy. How do we get diacetylmorphine? How do we expand options and coverage on the Ontario drug formulary? How do we get politicians to support this work and make actual policy changes that will enable expand? This is me paraphrasing a few questions here, everyone, so apologies. I hope I'm getting it right. But this is the general theme. So can we talk a little bit about that? What kind of advocacy do we need to do and what are some ways of doing it?
I think Jillian and I are both putting our big breath on because the answer is enormous.
Yeah.
I just let out the biggest sigh ever. I don't know if advocacy makes a difference at this point. To be honest with you, we've just lived through a period of 2 years where we watched our elders be massacred within long-term care, and we still haven't reckoned with that. During COVID, we are watching right now as policies of social murder become mainstreamed, particularly as it relates to the rights of people living with disabilities in COVID. I think, like, to be frank with you, I think that anybody who's living in conditions of marginalization and disadvantage right now, this is a particularly difficult time, and this doesn't just apply to people who use drugs or to Safer Supply program. We've, as a society, seemingly decided that it's fine to just throw people out on the street and live in tents without any kind of questioning or any kind of big discussion at our municipal levels about how we're going to provide affordable housing for the increasing number of people who cannot afford, as housing becomes more and more commercialized and commodified, rather than seeing it as a human right. It's basically a way for rich people to make themselves even richer. I'm on a little bit of a like soapbox right now, but like I don't know in this current climate how much advocacy makes a difference, because we've seemingly become completely endured to watching huge amounts of social suffering, to watching huge amounts of income inequality become normalized, without any kind of idea about what to do about it. OW rates right now are $700 a month, so there's no way that people can even afford rent in smaller centers where people used to be able to. So there doesn't seem to be any kind of movement whatsoever in terms of recognizing the ways in which a livable income is necessary. I don't know. I've been involved in frontline advocacy for many, many years right now. I mean, we can barely even get sometimes the media to cover the 60 and 70% increase in overdose deaths that happened during the pandemic. I don't know if advocacy right now is the answer. I think that we actually need broad across society movements in order to start really reinforcing how we need to take care of the most vulnerable among us. We need this, and this goes from everything to making sure that everybody has access to high quality childcare, affordable housing, healthy food to eat, to ensuring that people have access to primary care. I mean, we currently don't have a health system that's functioning in this province because everybody has COVID. And so I don't even know how we begin to advocate for these things in the current moment. I apologize, that's the most depressing statement I'll make today, most likely. But yeah, we're in full-scale policies of social murder right now.
I don't know if I can say that better, Jillian. I tell Greg, who is my clinical manager here, we call him my boss, but you know, no. Regularly, you know, when I was a much younger and more naive version of myself, I thought if I just did enough media articles, if I did enough interviews on the radio, that people would hear this and that they would care, that the problem was actually that people didn't know the information. I've come to the realization that that's not true. We're in our 7-minute segment world right now. We're hashtags and clicks to the next thing. And people know. If you don't know about the overdose crisis, I really don't know what patch of sand you've had your head in for 6, 7, 8, 10 years. I really don't know. And the same applies to, as Jillian was saying, about the housing crisis. I can show you where 200 people are sleeping right now. Income disparity. I mean, one of Jillian's slides was, you know, that people were more food secure, which means like we gave them food or access to food, and it only dropped 20%. So when we're living in a community, in a country, in a province that has people who don't have enough to eat and have burns from trying to have a fire outside of their tent in -20-degree weather, I think we have bigger problems of advocacy, and Safe Supply is just such a small sliver of that. Again, without, you know, whole-scale revolution and upending of capitalism, I'm not really sure, and I'm open to suggestions.
There is a suggestion in the chat. Megan. I just want to acknowledge Megan's comment in the chat. Megan, if I can speak for you, reading your words, I think what's required is reasons, motivation for people to be part of political processes and to form or reform political parties to actually represent the opposite of that bleak idea of essentially giving up on the social contract, i.e. substantive change towards equitable systems. So
Thank you.
political engagement, just to add some, some action-y possibilities in there, and away from systems based on capitalism. Megan adds. I'm just skimming through here. A lot of appreciation for your for this rant. Somebody put rant, which is great.
No, and I appreciate the people who are putting in the ideas into the chat about how the lack of consensus. Yes, and I do think so much that we do need to organize. I think it comes down to very, very basic community organizing. I think we need to start drawing the lines between the different coalitions and working together. Quite simply, we need to elect better leaders. And so I think that that's also a very, very clear priority. So yes, I think that there are, I just get very frustrated. I think we all are frustrated at this particular moment in time. It's been a long couple of years.
Just along those ideas around bringing people together, Dale, who's a researcher, makes a comment here. Given that there's a number of evaluations going on, should we consider an evaluation working group to streamline approaches and plan for syntheses in the future? And I'll take that because as the project manager for the National Safer Supply Community Practice, one of the things we are working on, there is a research and evaluation working group that's been happening through the Canadian Drug Policy Coalition. It's going to shift over to kind of live over the National Safer Supply Community Practice so that we can try to bring people together to talk about evaluations and how we can all work together and things like that.
There's also a National Safer Supply evaluation that is going to be going on, which is interesting in the approach, in that one of the major tasks that evaluation is going to be doing is bringing together researchers who are doing work in different areas of Canada and synthesizing some of the findings. And so I think that increasingly as well is going to be a very, very good approach, especially as we go into a period, I think in the next 2-3 years, excuse me, where we do start to see a lot of different research results coming out in numerous different locations.
There's also a number of questions relating to wraparound care, predominantly housing, and some questions asking about, is there a housing worker at LIHC that is connected to the program that the clients have access, Safer Supply clients have access to? And then I just want to read out Jacqueline's comment/question. For those of us from the housing sector and supporting high acuity individuals, advocating for the rights of housing, in particular for those who use drugs during this crisis, remains at the forefront of our minds. I hear what you are saying about structural concerns, and I agree, and it is good to hear about the positive outcomes of this program. However, can you please speak further to the sharing of meds? In our experience, Safer Supply clients dealing for long periods of time have created safety concerns for those who are street involved and has created barriers to maintaining their safe and affordable housing. Has there been conversations about the reality of this when it's not just sharing of meds, but trafficking from the home, and how to work with housing programs that are struggling with helping Safer Supply patients maintain their housing? In particular, how to implement some best practices to bridge the gap of oral SOS in housing? There's a lot in there, Jacqueline.
Yeah, and I'll start with that. So Jillian has already identified the most common way that people share or divert and stigmatize language on their medications. Most of it's to help family and friends. And we recognize and we know that, and that is the impact of poverty. Whenever as a program, we learn of people who are wholesale unloading their medications for profit, who aren't receiving personal benefit from those prescriptions, we have a conversation with those people, and we usually move them to non-take-home methods of receiving Safer Supply. But that being said, I think we really need to shift the conversation away from words like trafficking and consider that the root problem here is poverty. People can't afford their housing, they can't afford food, they can't afford winter boots or a coat, they can't send their kids a Christmas card because they have no money. And people are resourceful, people are resilient, and when an opportunity presents itself, of course they're going to try and improve their lives financially when they can. Does that mean we support it? No, we don't support it, but you know, trying to squash this idea of trafficking, I think we need to reorient that quite a bit.
And if I can just expand on this, because I've actually done some research on drug selling outside of this, not with London, not as part of Safer Supply. I can put my paper up in the chat if anybody's interested in reading it. But I think that we have to acknowledge the ways in which drug prohibition has framed sharing and selling of medications in a very, very negative way. And even taking a step back, people often talk about their drug sellers as very, very key parts of their harm reduction journey, and about how having a good drug seller who they can count on, and again, here I'm not talking about Safer Supply, I'm talking about more broadly, how having a good drug seller that they can count on is actually one of their major harm reduction tools that they utilize. And so I think that we've done a very bad job within harm reduction. We have to be able to be self-critical here. I think we've done a bad job within harm reduction at actually enforcing these kind of prohibitionist ideas around drug selling and not working with people in the community who are selling drugs, who, for the most part, are selling out of economic necessity, very small amounts in order to economically support themselves. I remember the first time that I was doing a focus group with people years and years ago, and they started telling me about the black market in Ensure. So the black market in meal replacement supplements, because people are so economically deprived and they have no way of providing for themselves, that they are selling the Ensure that they're supposed to be getting because they are malnourished. They're selling it in order to support themselves rather than actually using it to improve their malnourishment. And that was one of the moments that I really, it hit me how the economic disparities in our society and the extreme marginalization that some people face means that anything becomes a commodity. And so I think that we really need to, again, take a step back and look at the structural issues here. We've always known that there's diversion of methadone, and that has always occurred despite the incredibly strict dispensing requirements around methadone. And so I don't think that being super strict and observing every aspect of people's lives is the way that we're out of this. We've essentially tried that already within our OAT programs, and it failed. I think that we need to take the step back to the structural level and look at, number one, the capacity issues, which means that all the people who actually want access can't get it from a doctor and have to turn to somebody on the street instead. We actually have to look at how we can be regulating the supply and moving beyond medicalized models, because I think another aspect that we haven't talked about here today that's important to nonetheless mention is that medicalized models are not going to be the be all and end all here. And we need to be thinking about safer supply and regulatory distribution measures that don't rely on doctors, because a lot of people don't want to get their dope from doctors, quite simply. I think the other thing that we have to do is we have to actually think about the economic circumstances that people are in, and think about how we can have a livable wage and basic income for everybody, and meet people's economic needs in ways that it actually will address the fundamental issue that's the problem here, which is that people are so poor that they have no options but to sell some things that the rest of us really do take for granted, like being able to get a pharmaceutical prescription to meet our medical needs from our doctors.
Great, thank you. Shift gear a little bit. Here's one from Bob. Hi, Bob. So often medical interventions aren't accepted by mainstream medicine unless there are randomized controlled trials supporting their use. Since there are so many people on waiting lists for SOS programs, do you know if anyone is doing or planning any studies that accept people into SOS programs by randomizing eligible participants, e.g. by lottery? Do you think the results of such studies would have any impact on increasing acceptance of SOS? Do you think they would be ethical?
Can Jillian is a methodology research person. She's going to answer your question better than I can, Bob. But I just want to reflect a little bit on medicine, accepting randomized controlled trials for interventions. I would say yes, unless they don't like it. So I'm not really sure that an RCT is actually going to change the minds of our critics. And I would like to, reflect on all of the things that we do already in medicine that are off-label and don't have an RCT behind them. One really good example example is how we're currently using Suboxone. So, in the addiction medicine community, we've had widespread adoption of something called the Bernese method, which microdoses people onto Suboxone instead of the old way of making them be sick. We're actually having the emergence of something called a macrodosing protocol, where we add Sublocade on day 1 or day 2 instead of having to go to 30 days or more to help people use Sublocade. There is no RCT evidence on that. It is all based on best evidence practices, clinical expertise of the doctors who are pursuing those modalities, and so that's been accepted by the addiction medicine community. That is okay. But Safer Supply, which actually I would argue has a lot more evidence behind it at this point than those methods, no, we have to wait for the RCTs. So, I'm not going to hold my breath on the acceptance of that, and Jillian can go more into the ethics of an RCT, but I think we need to forge ahead with what we know is right.
Yeah, I think that, so I'll say a bit about the ethics in a second, but I think the thing about the RCTs is, would an RCT on Safer Supply be a good idea? Yes, I think that would be very interesting. Should we pause current Safer Supply programs while we wait 2 or 3 or 4 years for an RCT to occur? No, I think that would be vastly unethical. I think that we have to realize that we're in a crisis situation. Crisis often drives innovation, but I think that also there are other research methodologies using observational methods, for example, that we can also use. RCTs are not the only way that we can generate evidence. There's many other ways we can do it. I also worry because we have a huge amount of we have very, very strong RCTs on heroin-assisted treatment from several European countries, as well as from Canada. Has that led to widespread implementation of heroin-assisted treatment across Canada? No, despite the fact that we had a very strong RCT in Vancouver and Montreal, the Naomi trial that was trialing heroin against methadone, and strongly saw benefits for people who were treatment refractory, so had difficulties on previous treatments. We have not had uptake. They also did a trial of heroin versus high-dose injectable hydromorphone. Has this led to widespread, and they showed that high-dose hydromorphone was non-inferior to heroin-assisted treatment. Has this led to broad access of high-dose hydromorphone across Canada, despite the fact we had a very good RCT here? No. So I think that assuming that an RCT is going to be somehow a magic solution, that doesn't seem to be the way that it works, unfortunately. I think that this is partly to do with the stigma around drug use, and particularly around continued injection. I think one of the reasons that people are uncomfortable with heroin-assisted treatment and there hasn't been widespread uptake of the injectable OAT options is because, quite frankly, we're still really uncomfortable with the idea of letting people continue to inject. And so I don't actually think that it would make that much of a difference. As a researcher, would I love to see evidence from one? Very, very much. And I think that if you were to do one in an area where you didn't have access, you might be able to actually ethically do it. But I think that it would be very, very difficult. We've actually looked into doing this, and I could spend another 15 minutes talking about the reasons why doing an RCT around this would be very, very difficult. But yes, I mean, I think it's a good idea. I just don't actually think it will have the impact of broad-based research using a number of different methodologies in a number of different locations as programs are scaled up based on preliminary information that seems to show very strong effects.
Thanks, Jillian. Thanks, Andrea. Just noting the time, it's 1:27. I do want to take a quick minute to plug a couple of things coming up for the National Safer Supply Community Practice. If I can shift gears a little bit there, Andrea and Jillian, before I do, is there anything you'd like to, anything you'd like to say before we close?
Just thank you for being here. I really enjoyed the question and answer period. Maybe it's just because I like to rant and run my mouth, but I think there's so many questions in the chat and the Q&A that we just don't have time to get to. I look forward to answering them with Rebecca and communicating that to the community of practice.
Yeah, and we're meeting next week. So I will keep track of these questions and some of these key discussion points. And, you know, we can start off our meeting next week with a check-in to see what people want to chat about and revisit some of these questions, because I think these findings and recommendations do give us some things that we need to talk about as a community and think about how we can move this work forward. I'm so grateful for this report coming out. I think it gives us, I think it helps spark the fire and reminds us of all the great work that's happening, and different programs are at different stages. And London, you know, the program at London's been happening for 6 years now, which is incredible. And so being able to see you know, what kind of things are possible and what's coming out of that. There's so much for us to learn from the London program and things to share and talk about with the London program. So we look forward to more of those opportunities in our other meetings. We do have a couple of things coming up. We've got wound care workshops that are going to be happening. The first one is scheduled for January 31st at 10 a.m. Eastern time. So sorry for the BC West Coast folks. That's not going to work well for you, but we will have it recorded. And if you do have any questions or anything, we can hook you up. That's just timing is how it needed to work for that date. We do ask that you register for that. And I think, oh, look, Alex has already popped that in the chat. That's going to be an amazing workshop. It's geared specifically for clinicians. And the reason for that is so that the facilitators can come to the workshop with an assumption that there's a base knowledge that the attendees will have being there. But we also know that clinicians are not the only people who treat wounds. We know that a lot of people also look out and take care of each other, people who are not necessarily trained healthcare professionals. And so we will be having another wound care clinic, a wound care workshop for non-clinical people. So using like lay language instead of like hyper medical terms. And so we'll talk about how people can help support care for each other. The same facilitators will be there. We're just assuming a different kind of knowledge coming into that space. And we're just scheduling that. So we're hoping for that to be in February. We're just waiting to hear. It's going to be facilitated by one of the same facilitators plus a person who uses drugs as well. So stay tuned for that. In March 15th, we have Dolph coming to do a presentation. Oh, sorry, also, I skipped ahead, February 24th, Christy Sutherland, Wendy Stevens, and Leslie, oh, why do I do this to myself? Team, fill me in. McBain. Thank you. I'm so sorry, Leslie, if you're on this call, because we're really excited about you being there. The three will be presenting on decriminalization. So that's February 24th. And then March 15th, Dolph is coming to talk about their work and slightly different presentation, I think, from the others that they've been doing because they've been all over the place lately. So yeah. And we'll be launching our new updated website at the end of February, most likely, dates to be determined. Yeah, so lots of exciting things happening. Thank you so much for being here today. We're going to say goodbye, and the group of us who you see on the screen right now are going to stay on and just debrief and check in and applaud the amazing work that the Safer Supply program has been doing in London and the evaluation. Don't forget the website will have the recording and the reports there as well. You can share them. Thank you, everyone. Bye. See you next week.